Dear Dr. Brasse, for a couple of months I have been suffering from a dense cobweb in my left eye that is impairing my vision. This is impacting my daily life significantly. A vitrectomy is already scheduled. I am only 24 years old. I am scared to have this done. Are you able to help me in your laser floater clinic?
This slitlamp image reveals a completely detached posterior vitreous membrane. It has lost its transparency, which is the reason for the massive visual impairment. The central retina in the optoscan is hidden behind a dense curtain. For sure, this membrane is the reason for the severity of the patient's visual symptoms. To be able to better understand this unique case, a 3D model was built. The posterior vitreous membrane is detached but still sticks to the optic nerve head. In retroillumination, the posterior vitreous membrane shows a cobweb-like pattern. Here you can see kind of transparent pearls which are interspersed into the membrane. They look like deposits of an unknown origin. No cells or any signs of an active uveitis could be found. I have never come across findings like these, and I was kind of at a loss after the exam. For research, the online Journal of Ophthalmology is usually a treasure trove of information. The chapter Vitreous Images from Robert Makema sparked my interest. He described a case of familial amyloidosis. Those images resembled the ones in my case. Makema described them as glasswall-like opacities. A paper from Dr. Schuenherr and Dr. Groh about a female 50-year-old lady suffering from a primary vitreoretinal amyloidosis showed consistent medical findings with my case. A paper from Dr. Jeff Gaucher from Cleveland, Ohio, it says, punctate dots on the posterior capsule are considered pathognomonic of vitreoretinal amyloidosis. Reviewing my images, I could find those punctate dots on the posterior lens capsule, which confirmed the diagnosis. Just double-checking the literature, I found an article from David MacLeod. He says, nothing else in the vitreous looks like amyloid. Vitreous infiltration by amyloid proteins has a pathognomonic biomicroscopic appearance. Biopsy is not necessary. Is a pars plana vitrectomy the only treatment option? Like most invasive surgical procedures, vitrectomy is not risk-free, in particular in a 24-year-old patient. Reviewing the literature, I came across a helpful article from Dr. Kees van der Wind. Originally, the author has developed this technique to remove vitreous floaters and in particular vice ring structures from the optical axis to get his patients symptom-free. He did not vitreolyze the floater, but he did cut a hole into the posterior vitreous membrane to get the optical axis free. His technique is called laser T membranotomy. To be able to perform his laser technique, you need a special contact lens. The widely used Abraham contact lens allows you only to do laser treatments behind the lens and in the anterior vitreous. To be able to reach the mid-vitreous, you need a contact lens with a longer focal length. A perfect lens to perform a YAG laser T membranotomy is the Sing lens. Dr. Paul Singh from Kenosha, Wisconsin has developed this lens to perform YAG laser treatments of vitreous floaters. Furthermore, you need a YAG laser that is able to provide optimal illumination of the vitreous. It is mandatory to have a YAG laser with a light delivery system that allows good coaxial vision by converging the operator's vision, target illumination and treatment beam onto the same optical path. Ideally, you own a YAG laser with a retractable reflecting mirror, programmed to move out of the laser's pathway during firing mode. This ensures coaxial illumination at all times and enables full visualization of the vitreous. I was kind of nervous when I performed his technique for the very first time, in particular in such a young patient. I have split up this complex procedure into several sessions on 4 consecutive days. In total, 7,000 millijoule of laser energy were necessary to create an opening into the posterior membrane. This is almost 50 times the amount you need to perform a regular YAG capsulotomy. That is kind of risky, people might say. But isn't a vitrectomy in such a young patient not even more risky? Honestly, I was worried about her ocular pressure rise. But it did not happen, nor did I observe an intraocular inflammation. This postoperative slit lamp image is proof of the effectiveness of the laser T membranotomy. The Optos scans are even more impressive. Visual acuity improved accordingly to 80%. Now I am relieved to be able to tell you that after a period of 6 years no complications at all did arise. The young lady has finished her university degree and was even able to pass her driving license test.